Can vestibular-based therapies help patients with autonomic disorders? First, I want to be clear that these thoughts are not coming from any robust data sets from randomized clinical trials. These are all basically biological hypotheses and some lab-based studies that support some of the clinical things that we're seeing in functional neurology clinics. So with that being said, let's talk about one of the most common manifestations of dysautonomia, which is something called orthostatic intolerance. And when we talk about orthostatic intolerance, we're talking about a concept called orthostasis, which is the phenomenon in which there's a physiological shift in the body that occurs that happens when you go from laying down or sitting into a standing position. So this change in position and the physiological shifts that happen can become dysfunctional in a patient with dysautonomia that leads to the manifestation of these patients feeling a form of dizziness that is often described as lightheadedness or feeling faint. When someone is in a sitting or a laying down position, their cardiovascular system exerts less effort in order to maintain circulation throughout the body. As soon as someone goes from those positions into a standing position, their body has to fight against gravitational forces, which is pulling blood down into the lower extremity. If the nervous system is working well, then that process happens fairly quickly and automatically, so your blood pressure is naturally going to rise a little bit, or your heart rate is going to rise a little bit in order to make sure blood gets into the brain appropriately. But in a patient with dysautonomia, this system doesn't work quite that well, which means that there is a time lag in getting blood flow and oxygenation into the brain, which leads some of these patients to feel this momentary sense of lightheadedness, which if it's severe enough can cause people to feel faint, and ultimately some people may go into something called syncope where they faint or pass out. Conventional thinking attributes most of this process to the reactivity of something in your body called baroreceptors. So baroreceptors are these little nerves that sit inside of the top parts of your carotid arteries, and they're constantly monitoring the body for blood pressure. Every time your heart beats and blood gets into the baroreceptor, it creates a stretch response, and that stretch response sends a signal into the brainstem that tells you if you should increase your heart rate, decrease your heart rate, or increase your blood pressure, or decrease your blood pressure. When you go from laying or sitting up into standing, you're going to have a little bit of a drop in your blood pressure, and your baroreceptors in your neck are going to detect that, and it's going to send a signal to your brainstem, which sends a signal down into your IML of your sympathetic nervous system, and tells your sympathetic nervous system to increase your heart rate and increase your blood pressure so that your brain can get enough oxygen. But this likely isn't the only mechanism, because your brain is actually predictive in nature. So your brain should actually be sending feed-forward mechanisms just before you actually go to standing. Your muscles should be contracting and starting to initiate the sympathetic nervous system to prepare you for that process of standing up. We also have these systems inside of our inner ear called our vestibular organs, and in particular, the otoliths have this ability to detect changes in gravity, and when it detects these changes in gravity, it fires along these really fast pathways called your vestibulosympathetic pathways that go into the rostral-ventrolateral medulla of your brainstem, which then in turn activates the sympathetic nervous system in your spinal cord, and that also triggers a blood vessel response. And this response goes into the same pathway as those baroreceptors, but the otolithic inputs tend to be much faster at sending those signals than the baroreceptor signals. So practitioners of functional neurology have been using evidence from papers like this, the sympathetic responses of vestibular activation in humans, to use vestibular activation as a methodology to help patients with blood pressure regulation issues like orthostatic intolerance, especially orthostatic hypotension and POTS. While we don't have any good clinical trial evidence that suggests that vestibular therapy exercises helps patients with POTS, we do have some biological rationale, like this paper, which uses an electrical stimulation device called a galvanic stimulator to electrically stimulate the vestibular nerve, specifically the otolithic aspects of it, in order to help patients with postural orthostatic tachycardia syndrome reduce the fluctuations in heart rate that they have when they go from a sitting up to a standing position. So while we don't know for certain that vestibular therapy can help patients with POTS, it is certainly one of the things that is safe and well tolerated and can act as a bridge to increasing the physical activity and exertion of a patient with dysautonomia. And from the anecdotal evidence from many practitioners of functional neurology, I think you'll find that many of these practitioners see vestibular rehab as an important part of the rehabilitation of patients with POTS with good results.